Hello, good evening everyone. Today we are going to start with summary practice question, the USMLE practice puzzles that are related to our previous topics regarding the general pathology and growth adaptations and second cell entry. The first question is, a 32-year-old chef accidentally slices into the tip of her tongue while her bread brimming streaked with a knife. The laceration extends through the skin into a subcutaneous wound. Skin to subcutaneous, which is the following sequence, is most likely to occur in the subsequent wound healing process. In this MCQ, we have to give the right sequence of wound healing. We all know in the first step in the wound healing is fibrin plot formation. Okay, suppose you go with these two options, although they are wrong. Our second step is cerebral infiltrations, then it's alone, then last is angiogenesis. How these all the things are going on? Simply the wound healing having the four steps: hemostasis, inflammation, proliferation, and maturation. First is the hemostasis. In hemostasis, immediately after the tissue injury involves small vessel constriction, platelet aggregation, and clotting cascade activation that lead to platelet plugging, fibrin clot formation, and cessation of plating. For relatively minor injuries, hemostasis is often accomplished within the minutes, and maximum is from 1 hour to 1 day, but for the minor injury, it's accomplished within the minutes. The fibrin clot that is formed during this phase provides a supporting unit for the wound healing. And second is inflammation. In inflammation, if you really start within the hours of injury, during this phase, mast cells degranulate, releasing histamine and other chemical mediators that increase vascular permeability and promote cellular infiltrations, like neutrophils and monocytes. And secondly, these neutrophils digest bacteria, necrotic tissues, and foreign debris. The monocytes are transformed into macrophages, which secrete growth factors like transforming growth factor beta, and also there is a vascular endothelial growth factor. These all promote the next phase of healing that is called the proliferation. In proliferation, there is epithelialization, there is fibroplasia, there is an angiogenesis. What is epithelialization? In basic keratinocyte proliferation and migration of new epithelial cells form a new superficial epithelia that exceeds a barrier to the bacteria. New epithelium will be formed. And second, fibroplasia, new fibrous tissue will be formed. And thirdly, the angiogenesis, new blood vessels will be formed. But not last, the remoting on maturation. In the final phase of the wound healing results in the collagen remodeling and the cross-linking, which are primary mechanism by which the tensile strength of the wound increases. In which there is the formation of type 2 collagen and type 1, and this make a cross-linking of collagen and make the wound stronger and stronger. Now really moving to our next question. Our next question is, a 73-year-old man come to the emergency department with right-sided weakness and difficulty in speaking. The patient woke up with the symptom of aura before arriving but felt when he went to the bed last night. He has a history of proximal artery fibrillation, but is not at a high end with the medical therapy. Temperature is 98.6. Blood pressure is 130/70 and the pulse is 110 per minute and irregular. Physical examination shows a right-sided hemiplegia and hemisensory cirrhosis and aphaxia. Despite appropriate treatment, the patient's symptoms fail to improve over the next week, which of the following process is most likely to occur in affected brain region. In these MCQs, we have to level the necrosis, which type of a necrosis will happen in the central nervous system. In this, if you know, in brain there's a many type of a high number of enzymes are present to enter CNS. In central nervous system, they will occur effective necrosis will be happen and it is due to hydrolytic enzymes. And answer is a hydrolytic enzyme induced tissue digestion. If we talk about the different types of the necrosis, then there is a decomfective necrosis, coagulative necrosis, gaseous necrosis, phakic necrosis, and fibrinoid necrosis. If any ischemic attack, ischemic injury, if happened outside the central nervous system, then it most probably coagulated necrosis. If any ischemic attack and infection is happening in the central nervous system, then it will be liquid-creatic necrosis. But the fibrinoid necrosis is mostly due to the hypertension and vasculitis damage of the vessels that leak the fibrinamium complexes, and it having that eosinophilic layer or proteinous material in the vessel walls. In fact, necrosis could be due to acute pancreatitis and a trauma due to trauma of the adipose tissues and subcutaneous layers. And cases necrosis due to mycobacterial infections and a fungal infection that make appearance like a cheese disease, like material composed of cell fragments and amorphous proteinous staples. So if any inflammation, any ischemic attack is happening in the CNS, then it will be nuclear-frictive necrosis. Outside the CNS, it will be coagulative necrosis. Our next question is, a 46-year-old man present to your office with a slowly growing neck mass. The mass is strongly hard. On palpation and seen to the fixed, and after initial evaluation, combination of chemotherapy is prescribed to the patient. Several weeks later, the mass significantly decreased in the size, and biopsy demonstrate many shrinkage eosinophil cells within the tumor, which is a foreign substance that released from the mitochondria, most likely triggered to observe several changes. Actually, in this mechanism, the cell size is increased after sometimes cell size is getting shrunken or decreases. It due to which substance, and it's a substance that is released from the mitochondria. So, from the mitochondria, you all know regarding that type of mechanism, apoptosis. In apoptosis, a substance called cytochrome C is released from the mitochondria. And cytochrome C is a mitochondrial enzyme that activates the TAT species and indirectly bring about cell death through intrinsic pathway of apoptosis. And Eucor is known apoptosis is a means of carefully regulated cell death in which the cell activates enzyme to degrade its own nuclear DNA and proteins. Simply, it is a natural cell death phenomena. If you guys move to the next question, the next question is, a 65-year-old man come to emergency department due to acute onset, severe right flank pain, nausea and vomiting for the past hours. His medical conditions include prostate cancer and membranous nephropathy. Blood pressure is 148/60 and the pulse is 95 per minute. On physical examination, the patient appeared to be moderate distress due to the pain and diaphoretic. Okay? This is right costovertebral angular tenderness, urinary lysis hematuria, and in contrast, enhanced scan reveals the wedge-shaped perfusion defect in the right kidney. The affected renal tissue is most likely to develop which of the following histological changes from the next laboratories. Actually, this all phenomena is speaking about the ischemic attack. Okay, and already we discussed about if there any ischemia or ischemic attack or infections happening in the CNS, if we call the effective necrosis, but now they are asking about the kidney. If any ischemic attack is happening outside the central nervous system, like kidney, lungs, or in liver anywhere, then it will be coagulative necrosis. Answer will be coagulative necrosis, because in MCQ he's asking the condition the patient is describing now. Okay, if he will be persist with this condition in upcoming days, in several next days, what things will be developed in right kidney? It will be coagulative necrosis due to ischemic attack. Okay, understand? And guys, if you guys move to our next question, and it is about a 24-year-old man evaluated for recurrent episodes of abdominal pain and a bloody diarrhea. The patient has also low-grade fevers and fatigue. Physical examination reveals left lower quadrant tenderness. CT scan of abdomen showed technique of distal colon and rectum. During one of the laboratory tests, the patient anticoagulated blood is placed in the upright king glass tube and left undisturbed. His red blood cells from check and settled to the bottom at a fast rate of 50 mm per hour. Serum levels feature the following substances most closely associated with these observed findings. First, we have to diagnose the case. Okay? He having the abdominal pain, bloody diarrhea. And secondly, having a thickening of distal colon with the rectum. If you guys know, the most probably the case of the ulcerative colitis because it's involving the rectum with the bloody diarrhea and abdominal pain. Okay? And this patient who had recurrent abdominal pain and bloody diarrhea with the CT evidence of bowel valve thickening in the distal colon and rectum likely had ulcerative colitis. In chronic inflammatory conditions are characterized by the persistent stimulation of neutrophils and the macrophages, leading to the long-term elevation of circulating pro-inflammatory cytokines, such as interleukin-1, interleukin-6, and tumor necrosis factor alpha and interferon gamma. The liver responds to these circulating cytokines, particularly interleukin-6, by generating acute phage reactants, protein that modulates and inflame the inflammatory response and play some important roles in innate immunity. For testing about the ESR erythrocyte segmentations, the one factor that is involved in all the things is interleukin-6. Okay? Because it's the one ulcerative colitis. It's a chronic inflammation. And chronic inflammation mostly contains its mostly circulate elevation of pro-inflammatory cytokines. And always remember that the pro-inflammatory cytokines involve interleukin-6, interleukin-1, tumor necrosis, factor alpha, and second, interferon gamma. Okay? So it answers interleukin-6 because it is a chronic inflammatory condition. And guys, now we have to move to the next question. A 64-year-old man presents with diarrhea, abdominal pain, nausea, vomiting, and anorexia from the 3 weeks after starting radiation therapy for prostate cancer. Okay? Physical examination shows abdominal tenderness. Sigmoidoscopy reveals hyperemia, edema, erosions, ulceration of intestinal mucosa. Stool in the serum chemistry is a normal. Radiation enteritis is suspected, which is found with the most likely the primary mechanism responsible for these patient intentional changes. What intentional changes? Diarrhea, abdominal pain, nausea, vomiting, and anorexia. This patient with the signs of acute radiation enteritis because he were already going without radiation therapy, and these acute radiation enteritis include the abdominal pain, diarrhea, inflammation, and the inundation of intestinal mucosa. And 3 weeks after starting the radiotherapy for the prostate cancer, therapeutic ionizing radiations are commonly used to treat or palliate many types of cancers and causes all cell limits through two primary mechanisms. First, DNA double-stranded breakage, in which the breakage of both strands is required and single-stranded breaks can be repaired by the polymerases. And second is generation of reactive oxygen species, that is unstable molecules formed by the ionization of water oxygen-free radicals that can cause cellular and DNA damage. And in these, all the things, radiation-induced DNA damage, impaired mitosis, and initiate the apoptosis of susceptible cells, including the intestinal crypt stem cells and other highly proliferative cells like cancer cells and hematology and necrosis. And these severe damage also induces an immune response characterized with increased expression of pro-inflammatory cytokines like interleukin-1, 6, tumor necrosis factor alpha, and migration of leukocyte-like neutrophils to the affected tissues. And these processes that produce additional reactive oxygen species and contribute to radiation-induced tissue damage in the gastrointestinal tracts. These changes result in progressive inflammation, edema, and mucosal denudation that can decrease their absorptive area, and abdominal pain and diarrhea typically manifest several weeks after the due therapy is started. In some cases, the effects of radiation exposure can be delayed until years after radiation exposure and present as a complication of intestinal fibrosis, extravasation, and bowel obstruction. According to that, already I told you, in these all the things, there are two steps, okay? There are two steps to treat or palliate metastatic cancer cell. First is DNA double-strand breakage. DNA double-strand breakage. And third, generation of reactive oxygen species. And already there is an option of generation of reactive oxygen species, because these become anti-staphylococcus unstable molecules that are formed by the ionization of water and oxygen-free radicals that cause that sovereign DNA damage. And these oxygen species can cause that intentional changes. Okay, hope it should be understandable. I again saying one thing, that radiation therapy kill the cells by the two things: first DNA breakage, and third genetic of reactive oxygen species. And this mechanism can cause all these diarrhea, abdominal pain, nausea, vomiting, and anorexia after the radiation therapy. Now we are going to the next question. A 74-year-old woman. 74-year-old woman comes to emergency department due to 2 days of left leg pain and numbness. She had a history of atrial fibrillation and hypertension. Her left lower limb is pale and cold to palpitation below the knee. Arterial fibrillation shows an occluding thrombus, and left femoral embolectomy is performed. Both procedures draw slits, pedis and posterior tibial pulses become palpable. Several hours later, the patient began to experience with left calf pain. On repeat examination, the left calf is swollen, tense, and tender, and the pain worsened with the dorsiflexion of the foot. The disturbance is absent. The physician suspects injury of the reperfused muscle is apart due to overproduction of reactive oxygen species. Which of the following enzyme is most likely help to neutralize a toxic molecule? Guys, I want to share one more quick with you whenever you are doing any clinical-based question like this. Try to read last 2 lines first. Okay? Like the first line in, last line in which of the following enzyme is most likely to help neutralize this toxic molecule. The last statement you can get, but you have to answer. You have to answer any enzyme which neutralize a toxic molecule. Next, we have to read secular. The physician suspect injury of the reperfused muscles in the past due to overproduction of reactive oxygen species. In last 2 statements, we go to our question. You don't have to read all the statement. If the questions are time-based, okay, the question is, which enzyme is going to neutralize the toxic substance and toxic substances, reactive oxygen species? As you guys all know, in mitochondria, there's one enzyme superoxide dismutase that neutralizes reactive oxygen species. I also have a diagram with me. This one, like if any radiations, toxin, reperfusion happening, and they will be production of reactive oxygen species. This superoxide is converted into hydrogen peroxides by the help of superoxide dismutase, and this will neutralize into water by the help of catalase or glutathione peroxidase. If these become again dihydroxyl radicals, then it will be due lipid peroxidation, protein damage, and DNA breaks. But now, for the neutralization, we have one enzyme in mitochondria. This is superoxide dismutase, okay? And this all about our today's MCQ practice session. For more practice, you guys can go to YouTube of Dr. DC Online. When you guys search on this, you can click on the pulse session. There's a many MCQs idea. By the name of USMLE Practice Pulse.